I should have gotten that on video.
Okay, what did you find out about CNS? What is the normal type of treatment for CNS tumors, brain tumors to be precise? What is the normal type of treatment that you would give for a brain tumor? Primary brain tumor. What? Anybody?
Can we look at our notes?
Pardon?
Can we look at our notes?
No.
No, I don't know.
So, what's the primary treatment?
A lot of it seemed like multi-field IMRT feedback, 50 to 54 grade for a lot of it.
54 grade, okay. Would that be primary brain tumor?
Individually,
No, there's two types, there's primary and there's secondary, or primary and metastasis. So 5400 with VMAT or IMRT, what would that be used for? Primary. Or metastasis?
Primary.
Primary, okay. So 5400 to about 6000 is the normal range for primary CNS brain tumors. What about palliative brain tumors, metastasis? What's the average dose for those, and how would you treat them?
3,000 centigrade.
3,000 centigrade. Okay, just 3,000 centigrade? Or is there wiggle room?
Wiggle room.
Is there any other dose that you would give to a metastatic brain tumor?
24 to 26.
In how many days? So, Asia, you said 3,000. In how many days?
I'm kidding. Mallory said it.
Okay.
How long is it, like 5?
I don't know. I would say 10 days.
Okay. So it's 3,000 times in 10,
You could have taken
which is
it.
300 times 10. Okay.
Yeah. I don't want to take credit for your work.
2,400
For your brains.
That's it. Was it somewhere between
My brain
24
too.
and 26? I'm just pulling numbers that I remember reading it.
And you're talking about how many fractions?
I said 5 and
5 to 10.
yeah, like SRS or
Okay.
fraction.
So you're talking SRS or fractionated, which, okay. Okay.
I don't remember a lot of details between
So-
pages 29 and 45.
You got your book with you?
Of course she does.
Okay.
We sit next to each other. Neither of us have a book.
Which specifically
And then
were you
we're just
asking
gonna
about?
sit. Like a
I'm asking
reminder of
about
what they were talking
metastatic brain tumors.
If I do dosimetry in the future, we'll get it again.
I asked my dosimetrist if she feels like she gets paid enough to do this job. She says,
Is there anything there on metastatic brain
the doctor
tumors?
said I don't get paid enough to be a doctor.
Dosimetrists get paid enough to do? That's good. My body is always blood, so I don't feel like I'll be able to.
So here's the SRS. So we have
That's all.
adenomas.
Eventually,
So
I need
you've
to
got
make a break,
20 to 25 is probably what you saw. So there isn't anything on metastatic brain tumors. Metastatic brain tumors can vary from about 3010 to about 4015 centigrades. Okay. So what can you tell me about non-cancerous tumors being treated with SRS?
What do you want to know?
Tell me what you know.
Nothing.
Nothing.
There's something in here that says arteriovenous malformation, or AVM.
I remember that
Okay.
word. That word.
So, it's actually 2 words, but that's specific.
Yeah, I remember that small sentence.
So, can anybody tell me what an AVM is?
It's like a glob of the
EVM?
vein,
An AVM.
where the, I don't know, the capillary bed,
Arteriovenous malformation.
where they all bunch together or something, and
What all bunched
then
together?
the vascular system, like, so like the arteries go into the capillaries, but they bunch with the veins. I
Yeah, so
read about it, but it was
It's
a mess,
like
like a good
a
bunch
big knot
of, right.
of both veins and arteries that get sort of mixed up. And it can cause problems, especially if it's in the brain. It can cause problems with blood flow to the brain. So that's why they use most of the time stereotactic radiosurgery for that type of thing.
So what is their goal with that, to actually,
It loosens it up.
oh, it loosens it, it
Yeah.
doesn't stop the flow through.
No, it just
Right?
loosens it up. They're not sure how it does it, but it does it. So, yeah. The other one is what they call acoustic neuroma, and I don't think there's anything in here about an acoustic neuroma. So what does everybody think that might be? Acoustic neuroma. Again, it's a benign condition.
Is it like a hearing, like your acoustic nerve, there's a tumor around it or something?
Yeah, it's a benign tumor that forms either around or close to the acoustic nerve, which is one of the cranial nerves, right? And basically, it's close to the ear, so they can actually do stereotactic radiosurgery to reduce that tumor, and the patient can hear again. So, all of these brain tumors. What's so special about the meningioma? Did anybody actually read the chapter, or they just looked at it and wrote stuff down? They just looked at it and wrote stuff down, right? Yeah, okay. So,
Kind of.
what's so special about a meningioma?
It's inoperable.
Pardon?
Inoperable.
No,
That's what it says here.
It can be inoperable or there's post-operative treatment.
what I want to know is, that it can be benign. Majority of the time it is benign, but it can also be malignant. If it's benign, they usually leave it as is. They don't touch it, usually.
It's pretty rare.
But if it's malignant, then they would try to surgically remove it. If they don't totally remove it, then they hand it over to us for radiation therapy. So mobilization for brain tumors. What's the standard for brain tumors for mobilization? For primary brain tumors that you will be doing IMRT.
Mask.
What kind of mask?
I don't know.
Thermoplastic.
Thermoplastic.
Thermoplastic mask.
There's so many
Okay.
different types.
There are several different types. Which one?
I've done both of those.
What is this one? Why?
Bands.
More sturdy? Okay, which means what?
Not moving.
I'm gonna be
Well, they
honest.
can move, but not quite as much.
I've only used the other one.
You've only used this one?
Yeah.
Really?
Yeah.
They're cheap over there.
Yeah. It was in Gainesville.
Yeah. So this is the one that's normally used for MRT.
I made one of those and the guy freaked out. So I had to make another one. So I made like 4 last week. He's a mouth breather, so I understand his pain because I can't breathe through my nose either. I said open your mouth and breathe through your teeth because that's what I do. Because I don't want to sit there like, so I want to breathe through my teeth. So I said try to breathe through your teeth. And he was like,
He was saying he couldn't breathe.
yeah. And he didn't have a light block. So I was like, just breathe through your teeth.
What happened to his nose?
He's a mouth breather. I can't breathe through my nose
Okay,
either.
well, that's fine.
So I was
He's
like,
a mouth breather, but you could put something in there, just maybe a little tube or something, just to keep his mouth open to help him breathe.
yeah. I was like,
That's
I get it,
possible.
because I can't breathe through my nose for too long either.
No.
So I was
So
like,
in that case,
we actually kept taking it off and putting it back on.
yeah,
We were like, we don't want it to take off it too long because it'll shrink.
that's right.
But we took it off for like 2 seconds, told him like take some deep breaths and put it back on.
Yeah. Well, in that case, what I would do is ask the physician if you can put maybe a little, not a mouth bite, but a little tube in to help his mouth keep open, and that way you can breathe.
It had to be something like that they wouldn't be able to fall back their throat, right? And
Oh
swallow.
no, but you grab it with your teeth,
Yeah.
so it's not going to go anywhere. And you don't have to put it in all the way. You just put it in. If it's a tube about this size, you can just put it in about this much, just enough to catch your teeth.
Yeah, that works.
And it's about usually about an inch. It's usually an inch in diameter. So depending on what area we were treating, what area we were treating, do you remember?
I did so many last week.
Okay.
It
that's
was
fine.
so.
What's another name again?
I can't remember.
Anyway,
But I was trying to explain to him like this is the longest you'll ever have to keep it on. He also didn't talk very well. So I don't know.
Okay. So what can you tell me about whole CNS treatment? Whole CNS. What do we use it for? What type of treatment would we treat whole CNS? Medulloblastoma. Okay. So what kind of dosage would we use for that?
that come down from the left class.
Mhm. Let me, possibly would be in the pediatric area. Okay, so let's see if I can.
You guys are gonna fucking leave now. I know. Stupid bitch. I know. You and Anisha are the only people that are like, why are you leaving?
I don't have doses on that, but I'll get some doses for you. So this is the whole CN. Okay. Okay. So how do we treat whole CNS anyway? Let's just get back to that. How do we treat whole CNS? Anybody?
My notes, I have 1 to 2 fields depending on the length of the spine.
Okay, before you get to that,
Parallel field, top fields.
parallel, not say pop. That doesn't make any sense. Parallel opposed
This is
pair
what I get when
or
I get
parallel opposed fields.
infusions. That's
Okay? Pop doesn't mean a damn thing. You have to specify.
targeted.
So parallel opposed fields for the
This is targeted there.
brain and whole spine. What how is the patient positioned? How is the patient positioned? Anybody?
Supine.
Prone.
Supine.
Head down. Head lower than body.
Okay.
Head down.
The longest.
Like supine?
Prone. Prone.
Prone? Okay. Don't yell at me, Megan.
Head down. Like chin to chest.
Prone. Are we waiting for her or is she waiting for us?
Okay. So how is so the patient's prone. Somebody said head lower than the body. Why?
Stretch out your spine.
Straighten out the spine. Yeah. Straighten out the C spine, actually.
try, Megan. Well, I don't, so.
Because I was making a mask and I put this right here. And this I was like stabbing the patient. So I got them cut. Okay, so. What's the most common primary brain tumor in adults?
Come on, we all know this answer.
Told you last week, guys. Most common primary brain tumor in adults. Is what?
We all know it. Somebody just say it.
GBM. And what does that mean?
Glioblastoma multiforme.
Glioblastoma multiforme.
Multiforme.
Why do you think it's called that? Glioblastoma. Okay, the glioblastoma thing is reasonable. What about multiforme? What do you think that means? Tends to spread out into little pieces around the main tumor. It tends to spread out in little sort of areas around the main tumor.
Seemed like an easy question like that everybody knew, but nobody wanted to say it. It's like, I'm scared.
Why are you saying?
Because
I'm fucking scared.
yeah. She's wrong. I told you that last week. It's different today.
So,
It's different every week.
so, what about
God, that shit smells so gross.
This just smells like beef and cheese.
I'm like kind of plant-based now. I'm not eating much meat.
looks like we're stuck for CNS. Looks like we're okay. So let's go and we'll do rest. So chapter 5. So when we're treating breast, what do we do? What kind of treatments? Our patient comes in with breast cancer. And they've been diagnosed with breast cancer. They've had surgery or at least a lumpectomy. And they have breast cancer. What are the treatment options for that right patient? Treatment options for breast cancer.
Surgery, radiation, and chemo.
Surgery, radiation, and chemo. Okay.
Christine
All of the
says it.
patients have surgery, radiation, and chemo?
Or
Do all of the patients have surgery?
Probably most.
Some type of surgery, yes.
Most? So which breast cancer patients would not have surgery?
Someone who's not a surgical candidate.
Someone who's not a surgical candidate, okay?
We need to get around the correct answer.
What about the biopsy? Would every patient, breast patient have a biopsy?
Probably most. We have somebody that denied a biopsy, but it was not breast. So,
It was not breast?
no. I don't think. She
The
had.
majority-
No, it was. So she had like a primary, or I don't know if it was a primary, but she had something. And then in her notes, it said that there was like something, I think, in her breast. And she denied biopsy 'cause she just didn't care.
Oh, she declined the biopsy.
You can just decline biopsy. If you decline biopsy, you wouldn't get treatment, would you?
Probably not.
Because they don't.
99 times out of 100, no, you would not. There are some situations where, not necessarily in breast, but in other sites, for example, a brain. We've treated patients who have carcinoma of the brain and we have been able to do biopsy. And we've treated them because all the clinical signs say that that's what it is. But with the breast, you should really do a biopsy. So the majority of the cases, the majority of the breast cases
You got a lump?
have surgery, even if it is only a lumpectomy. So what would be the criteria for a patient only to have a lumpectomy as far as surgery goes? We're not talking anything else, but surgery goes. What would be the criteria for the patient to be told, okay, surgically all you need is a lumpectomy?
No notes involved.
No involved notes, yeah.
And then like a certain size, probably.
No.
Pardon?
Like a certain size. Like
Certain
My friend's
size,
mom just
okay,
had a
so
lumpectomy and it's
you
not very-
have usually
That just means that there's
T1.
only one small.
S, right? Which is what? What is the stage before it becomes infiltrating cancer?
DCIS, right?
Pardon?
Is it DCIS? Ductal carcinoma in
Inside
situ.
too.
In situ, no, not ductal carcinoma. Any carcinoma that is not infiltrating can be called an in situ tumor. That's what T1S usually is, or T0. So T1S or T0 is usually a carcinoma in situ. But you're talking DCIS, which is ductal carcinoma in situ, which is the most common breast cancer, ductal carcinoma in situ, DCIS. The most common infiltrative carcinoma is ductal cancer, ductal carcinoma, without the in situ, because we're now talking stage 1 and up. So you have no nodes. How do you prove there's no nodes involved?
Scan. PET scan? Yeah, scan. Contrast scan.
Guess you remove them and biopsy them.
Hmm?
Do you remove them and biopsy them?
To have no nodes involved.
You can remove and biopsy them, but there is one way before you actually remove them.
A scan.
Do you remember something that we describe that we put dye in, and it goes to the first node. What was that?
Seminal node?
Seminal node, yeah. So basically you do a dye, you put it into the lymphatic drainage and follow that up. And the first node it comes to is what is called the sentinel node. You look at it, you find out which node it is, you biopsy that node. If that node does not contain any disease, then you can say, okay, she's node negative. And then you would do a biopsy, or you would do a lumpectomy.
Is that a PET scan? Or
No.
How do they do that?
They do it, not a PET, but it's done in NucMed. It's not a PET scan. It's done in NucMed. So that would be how they normally find out whether they're node negative. So they have.
Finish. Go ahead. You got it.
No, go ahead.
I was just gonna say something about contrast. I don't know how like any patient would want to put the contrast through their port. It looks way more painful than just getting an IV contrast.